Hello, my name is Tu Lei. I am the chair of the Kidney and Cardiovascular Disease Council for the American Heart Association. And it's a pleasure for me today to interview Dr. Nora Franceschini, who is our Donald Seldin Lecture Awardee for 2025. This lecture allows experts in the field to bring the latest basic translational and clinical information to the American Heart Association meeting. The lecture is named in honor of Dr. Donald Seldin, a pioneer and a leader in the field of cardiovascular disease related to kidney failure. Dr. Seldin was responsible for seminal observations related to sodium-potassium transport in the kidney and their effects on blood pressure and cardiovascular homeostasis. Dr. Franceschini, would you like to introduce yourself?
Yes, sure. I'm Nora Franceschini. I am a nephrologist at UNC Chapel Hill and also a genetic epidemiologist.
If you could just tell us briefly about your topic that you chose to present, which is the genetic risk of chronic kidney disease in special populations.
Yeah, so this is, I think, is an important issue in terms of genetic field, is specifically, studying populations that are being understudied in general, and not just for kidney disease, but also for other cardiovascular and metabolic disease. So the main topic that we're going to talk about tomorrow is about the presence of this population we call population-derived variants, that are populations that are specific to groups, some specific groups, and they confer risk for the specific chronic kidney disease. And these populations, if they're not being studied, they will essentially not going to identify these risk factors that are important for the health of these particular groups.
So, what got you interested in the topic and to pursue this line of research?
So it's being, very clear for me from the beginning that I started doing research, that these are the populations need to be studied, and specifically because, the medical impact that you see. So you see in the clinics, they are overrepresented as patients in dialysis and other clinical settings. In addition to, all these statistics for public health, they are very increased burden of disease. So there was always very clear for me that these are the groups that I'll be working, that I was interested in.
Can you tell maybe a key message to the audience, to the lay audience? What's the take home message for them and how your research might impact clinical practice?
So I think in chronic kidney disease field, we have a fantastic example of variants that are population derived or population specific, depending how you want to define this. That's the APOL1 genotypes, high risk genotypes. So they are just present in individuals of African descent. So they are African Americans in the U.S. And, they use a large impact in that population is variants that are modified or by, environmental factors, so inflammation, so we have this great example. So in my research, I'm trying to find variants in additional populations. So the, individuals that have ancestry from the Americas or Amerindian ancestry. And I think, identifying these variants that have a large effect or even a moderate effect that can benefit, in terms, as APOL1, there is now, therapies under development and things like that. So it can help both to potential prevent, if we identify factors can prevent, but also can help with treatment, development of potential interventions for, so I think that's, so we just kind of lucky to have a great example.
Yeah. So clearly your work has a lot of implication for precision medicine or personalized medicine. How do you think your findings in the population will then translate to, let's say, when a provider, clinician is just seeing a patient who is from these special populations? How do you think that they can apply what your finding is in terms of risk stratification for your patients, et cetera? In other words, how soon do you think we can implement the findings that you have to basically apply that to precision medicine in the clinic?
I think we are still, I think touching a very important point. I think we're still very early on the phase. We don't know until we find the variants, so the application can be very quickly. One of the things that are happening now, we actually is doing this polygenic scores, and that's being proposed already for clinical care in the cardiovascular field. In the kidney field, we're still kind of behind on that. But this polygenic score is essentially using variants across the genome. And again, there is, much lower performance if you use, in populations that are not being studied. So if you apply them from, for example, European ancestry populations to these special populations, the performance is much lower. So there is implications in terms of clinical care if we decide to apply this for risk prediction, for, as you say, stratification, high-risk individuals. If you even decided to use this for decision therapy, if you don't study these particular populations, they are going to be behind when you apply this, these tools to clinical care.
Well, thank you so much, Dr. Franceschini, and you clearly are doing amazing and very important work, and we wish you all the best with continued success in your research. That will undoubtedly have a significant impact in the special populations that you study.
Thank you.